Good morning. I thank STEM India for this opportunity. First, we'll start with some of the basics of coronary atherosclerosis. As we all know, coronary arteries have two parts. One is your lumen. The second one is the vessel wall. Vessel wall has three parts. One is your intima, that is inner layer. Middle layer, media. Outer layer is adventitia. As we all know, atherosclerosis is a disease of intima. Once the disease progresses, atherosclerotic material accumulate in the intima, which is called as atherosclerotic plaque, and which in turn causes narrowing of the lumen. There are various stages in the atherosclerosis. The early stages are your intimal thickening, where the normal intima thickens and forms a little increased thickness of the layer. And the second one is your intimal xanthoma, where macrophages accumulate in the intima. These are all non-atherosclerotic lesions and are reversible. When it progresses into later stages, where there is accumulation of the extracellular accumulation of cholesterol, that marks the early stage of atherosclerosis, which is called pathological intimal thickening. With the further progression, this extracellular lipid and further macrophages that result in destruction of the extracellular matrix that forms a necrotic core, that forms a generation of fibroathyroma. When there is less destruction, it is called early fibroathyroma. Here the lumen is big and fibrous cap that is separating the lumen and your lipid, the necrotic material is thicker. And later stages, lumen is smaller and there is a big necrotic core, but still there is a big separation between the lumen and the necrotic core. When the separation becomes thin, that is a thin fibrous cap that separates the necrotic core and lumen, this is called the thin cap fibroathyroma. The next stage is a thrombus formation that resultant ACS. It occurs due to two reasons. One, early fibroathyroma and pathological thickening. There is endothelial disruption that results in thrombus formation, that is called erosion, or the plaque can rupture. This fibrous cap can get disturbed, necrotic core exposed to the lumen, that forms thrombus, that is called the plaque rupture. These are the two things I was just talking to you about. This is your plaque rupture and intraluminal thrombus formation, and this is plaque erosion, and that results in again intraluminal thrombus formation. This may or may not result in MI. If it does not result in MI, this again stabilizes, that forms further reduction in your lumen. So this is one of the repeated rupture or erosion and healing is one of the mechanisms of your lumen harrowing and increase in the plaque volume. Another important mechanism of increase in plaque volume in case of no thrombus is intraplaque hemorrhage that happens inside the necrotic core, that again increases the plaque volume and narrows the lumen. So all these things, if they don't result in myocardial infarction, later stages, they heal and form either total occlusion of the lumen, that is called chronic total occlusion, or they transform into calcified plaque, so that is called fibrocalcific plaque. Fibrocalcific plaque, when later stages fracture, it forms nodular calcium. Sometimes this nodular calcium can disturb this fibrous cap and protrude into the lumen, that again cause ACS, that is called the calcified nodule-related ACS. This is in a nutshell about various stages of atherosclerosis. And there are some features which make the plaque vulnerable for rupture. What are the various features? One is a large plaque volume. Second thing is presence of a large lipid core or large nephrotic core, or thin fibrous cap which separates necrotic core from the lumen, or the presence of the vessels that develop from the adventitia, that is called neoangiogenesis, and the presence of cholesterol crystals, or presence of macrophages, or the presence of small calcification. All these features make the plaque vulnerable for fracture, for rupture. And now move on to a different type of imaging and their various roles. The first one, various roles are rule out CAD, stenosis quantification, assessment of plaque vulnerability, and assessment of different pathologies of ACS, and guidance for treatment if in case patient needs stenting, and evaluation of non-atherosclerosis related various causes of ACS. Different modalities: coronary CT angiography, cardiac MRI, IVAS, OCT, and near infrared spectroscopy. These are the various modalities available. First, we'll start with CTCA. CTCA gives good information about presence or absence of CAD, stenosis quantification, and assessment of vulnerability. So what are the various things you get from CAD? One is plaque information. What is the exact type of plaque? And the second information is how much plaque you have in the artery. That is called plaque burden. Third information is how much this plaque causes luminous narrowing. So that is the third information. The fourth and important information is whether this narrowing causes significant ischemia or not, through either perfusion study or through CT performed. So these are the comprehensive information you get from CT. Sometimes you get rare non-atherosclerotic causes of ACS can also be ruled out by using CT coronary angiography. What are the CT features of vulnerability? As I already said, we have a large atherosclerotic plaque volume and presence of a large lipid and presence of thin cap fibroadenoma, that is called as napkin sign, or presence of small calcium, that is called as spotty calcium, or the presence of extravascular inflammation. These are the various features on CT that predict the plaque bone for rupture. And CT, you just see that gives comprehensive information about human narrowing, about the plaque burden, presence or absence of ischemia, and gives comprehensive guidelines how to go about further based on these CT findings. So what are the various indications in ACS? When the patient is low risk, normal ECG and negative troponin, intermediate risk or high risk with the normal ECG and equivocal troponin, where you rule out, you want to rule out other causes like pulmonary embolism, aortic dissection, that is called a triple ruler. These are the various areas the CT is recommended for initial evaluation of ACS. What about the CTCA related plaque vulnerability? Patients with adverse plaque characteristics such as large plaque and a large lipid for high risk for coronary death or non-fatal myocardial infarction. And what about CTCA with the standard evaluation of chest pain? There are multiple studies which evaluated compared CTCA with the standard of care in acute chest pain evaluation. So CTCA has an excellent tool for ruling out significant CAD in patients presenting to ER with chest pain, with equivalent outcomes to other modalities, and significantly reduce the cost and length of stay. And downside is there is a small increase in invasive coronary angiography and revascularization. This is in case of the low-risk patients. What about in NSTEMI, where there is troponin positive? CT has a very high negative predictive value, sensitivity, and a positive predictive value comparing to invasive coronary angiography with acceptable specificity. And when you use the CTCA for evaluation of NSTEMI, there is reduction in the length of hospital stay, reduction in the healthcare cost, and it may be a standard of care in low-risk patient population. However, you have to get more evidence in high-risk troponin population before recommending CT for these indications. Moving into invasive imaging, again, we have this type of invasive imaging. Comparison to CT gives information about most of the various areas in ACS. So two commonly used modalities. One is intravascular ultrasonography. Second one is intravascular optical coherence tomography. Comparing these two modalities, optical coherence tomography has 10 times higher resolution. That means 10 micron resolution, much closer to that of microscopy. However, it is limited penetration. You can see about only 2 to 3 millimeter into the vessel wall in comparison to IVUS, where you can see about a centimeter. For various aspects of your atherosclerosis quantification, OCT is much better than IVUS, except for plaque quantification because of its poor penetrability. And what are the various features? So on IVUS, what information you get? One is the plaque volume. And the second thing is presence of lipid. And the third thing is presence of small calcification. When you use radio frequency information over IVUS, that is called integrated backscatter or virtual histology IVUS, which codes different plaque components with a different color. So you can get exact measurement, exact identification of different components of your plaque. And the near infrared spectroscopy again gives information about presence or absence of lipid and necrotic core. And OCT best among the modalities, which gives information about all the components of vulnerability. Either you take the nuclear fibroadenoma, either you take the presence of a lipid, presence of a neoangiogenesis, and the presence of macrophages, presence of spotty calcification, and the presence of cholesterol crystals. So it gives tremendous information as close to histology as possible. And what about the plaque vulnerability and outcomes? So there are multiple studies using different modalities. In nutshell, the vulnerable features, presence of vulnerable features in these modalities increase the event rate, and the treatment with statin and antiplatelets reduce the event rate. And what about identification of different pathologies? We know there are 3 different pathologies. One is a rupture of thin fibrous cap that is called plaque rupture that forms thrombus and ACS. The second one is a disruption of the endothelium, which occurs either in the early atherosclerotic plaque, that is pathological endometrial thickening, or early fibroadenoma. So these 2 are responsible for plaque erosion. And the next one is, as we already discussed, this calcium, which can fracture and penetrate the lumen and come into the lumen. That is called your eruptive calcified nodule related ACS. So these are the 3 common causes of your ACS. And OCT, with its high resolution, identify different pathologies. Pathologies are divided into 3 groups. One is the destruction of fibrous cap. When you have an underlying lipid, that is called a plaque rupture, that constitutes about 65% of all ACS. The second one is when the calcium ruptures the plaque and protrudes through it, that is called calcified nodule. It constitutes about 2 to 8% of all your ACS. When there is no plaque rupture and only endothelial disruption and attached thrombus, that is called plaque erosion, which constitutes about 25 to 30% of all your ACS. So, but there is some difference between the plaque rupture and plaque erosion. This plaque erosion occurs commonly in women, smokers, aged less than 50 years, and most commonly it occurs closer to the bifurcation and in summer months. And because it occurs in the early stage of atherosclerosis, lumen compromise is not much. And in significant proportion of patients, they can be treated with only antithrombotics. Because of the less thrombus volume, they are associated with less microvascular damage when you do intervention with PCI and better myocardial perfusion comparing to plaque rupture. And the rare causes such as tight stenosis, presence of coronary spasm, presence of the spontaneous coronary dissection, which is similar to what happens with aortic dissection. And the next one is plaque fissure. So all these things again can be identified with your OCT. And again, plaque progression with repeated ruptures or erosion and healing that produces layered plaque can be clearly appreciated with your OCT. And moving to the final area where there is MI, but there is no occlusive coronary lesion. So how do you evaluate this thing? One is by using OCT, and the second is using by MRI. OCT gives you information. Some cases it may be erosion, some cases it may be spasm, and some cases it may be due to spontaneous coronary dissection, or rarely it can be a thromboembolic disease rather than in situ formation of thrombus. Sometimes OCT plays, MRI plays major role, ruling out patients who had tachycardic cardiomyopathy is nothing but a stress cardiomyopathy, which appears like an anterior myocardial infarction. And sometimes myocarditis and myopericarditis, which again may mimic ACS, that all can be differentiated by using cardiac MRI. So once you go for stenting, then again intravascular imaging guides to size your stenting, proceed with your intervention, and optimize your stenting. So to conclude, there are multiple imaging modalities in ACS. Low intermediate risk patients, CTCACA is a modality of choice. High risk intravascular imaging, assessment of culprit, and assessment of non-culprit for vulnerability. And if you need intervention, for guiding intervention. For MINOCA, intravascular imaging, particularly OCT and CMR, are the imaging modalities of choice. Thank you.